Since the 1990s, early 90s, and I have to say that I've been shocked and really amazed by how quickly RF for major joint pain has come on the scene. We're seeing not only denervation of the knee joint or genicular, if you'll allow me RF neurotomy, but treatment of using RF for shoulder pain, targeting the suprascapular nerve, the terminal afferents of the axillary nerve, the lateral pectoral nerve, as well as the hip, which I believe we're going to have demonstrated next. Okay, so this whole, for those of you that do spine RF, autonomic RF, blend pulse skin to both spine and autonomic, this is a whole new bucket of techniques that are becoming increasingly in demand. Now there's a couple as far as the device that I'll be demonstrating. You just saw a beautiful demonstration with the internally cooled electrode. And as I shared in my previous case, the Nimbus multi-timed expandable electrode, I don't know if you want to, was basically created to produce the same size and shape lesion. Essentially, it's prolate spheroid, 10 millimeter spherical, slightly off the central cannula in the direction of the tines, with about a 2 to 3 millimeter projection past the tines. The goal, I was using internally cooled electrodes in 2007, 2008, and I became frustrated with the cost of the electrode. I became frustrated with some of the glitches with the peristaltic pump and the tubing and the time that it took. So I wanted to come up with a solution that was safe, effective, and economical. And so I invented the Nimbus in 2009. So the technique, as you heard it described, is essentially the same as the technique I'll be demonstrating, with a couple of variants. I go slightly higher on the shaft, and on the superior target, let me turn around here. Can you flip that? On the superior target, I go above the inflection point between the metaphysis and the diaphysis. And again, the point is to touch bone just a little bit above the inflection. I don't go all the way down to the inflection, but about that high. And the reason is twofold. There are some dissections done by Peterson et al. That define the capsule, and it may be that I believe some of my failures in this technique were administering radiofrequency too proximal to the capsule, so I'm coming up a little bit out of the capsule. Secondly, is I believe that the vascularity is probably closer to the inflection, and although there have been no case reports of significant vascular injury from this technique, I believe by going slightly up the shaft, if you look at the anatomy, you're really not, okay, you're not losing much in terms of the coverage, and potentially you're gaining by being outside the capsule and away from the vessels. And again, advancing down along the bone. And you'll see that this is a post-arthroplasty knee. And in my practice, I see patients for genicular RF in sort of they come through two different doors. One are patients that have maybe a Kelvin-Lawrence grade 2 to 3 or 3+, and they've been told by their orthopedist that they're going to need a total knee arthroplasty, but they want to buy some time. And maybe the orthopedist wants to buy some time. So we're doing the procedure knowing full well that we'll probably end up with something that looks just like this. The other door they come through is after they've had arthroplasty. And I think it's important to realize that although knee arthroplasty is held out as a highly effective surgical option for intractable knee pain, the truth is that somewhere between 30 to 40% of patients are still having pain a year out that requires chronic narcotic or opioid use, which has certainly become a big problem in the United States. So, can you go a little bit, let me just push this a little bit this way. It's something about me and this x-ray machine. I think I just broke it twice. Are we good? So again, coming down more up on the diaphysis, a little bit away from the inflection. Let me have one more for the supermedial or the inframedial target. And can you go down just a little bit, please? Okay. So if we can have one lateral view, I'll drop. And a very important part in terms of the depth, I believe was mentioned, that the needle has to be about 60 to 70% of the way across from ventral shaft to dorsal shaft. And again, taking great care to make sure you get a true lateral, looking at the back of the patella there. Again, we're not going to be able to see with great clarity because of the arthroplasty construct. We'll go up a little bit higher. Just a little bit higher. And again, getting true lateral here. Okay, so that's about the depth that we would want the superior medial and superior lateral targets at. Can we come back to AP, please? There's two additional targets that I'll do as a routine. One is about 1 centimeter cephalad to the midpoint of the patella. And those are the terminal branches of the vastus medialis intermedius. And in patients that have any degree of patellar pain, I find this is useful. And frankly, you can take, after a single and my lesion times are 80 seconds, 80 degrees centigrade, I'll do a 30-second ramp, and I'll do one lesion. And then I'll do an additional lesion about right there, somewhere approximating the terminal ramification of the VMI. And in patients that have significant medial compartment pain, I will also place a needle posterior to the medial femoral condyle in the distribution of the infrapatellar branch of the saphenous nerve. So in addition to the 3 well-described genicular targets, we'll do terminal branches of the VMI and infrapatellar branch of the saphenous nerve. Questions?
Professor.
Yes.
My